Family physician for 36 years, so speaking is not my forte, so please put up with me a little bit. So long story short, as a family physician for 36 years, after I hung a shingle with a brother, and 8 years later I decided we cannot practice medicine like this any longer. We need to do something a lot different. So we found a like-minded group of physicians, formed a group called Primate Physicians, and our goal was really to take care of our patients a lot better than what we've been doing. And the biggest thing we looked at was chronic diseases. This is what really hurts the patients, and it also is extremely costly to our system, and they still to this day are not well controlled. With that, we began to look at Lean Six Sigma type quality theory, and part of that was because airplanes rarely crash, but our patients often do. And it's just the reality of what happens. So what are they doing that we weren't doing? So we began to look at process improvement, how to begin to do these things. We did everything on paper, and that's what all we had, paper charts, paper processes. And the first disease, I don't know why we picked it, was hypertension. It is an extremely difficult thing to control to this day. It's still very poorly controlled. But looking at different processes and different technologies and tools, we began to adopt these into what we were doing. And believe it or not, in the United States, back in 2000, the blood pressure control rate in this country was 32%. We weren't even measuring ourselves. Once we allowed ourselves to measure ourselves, we were fantastic. We were at 50% to goal. Half of our patients were not being treated well. So with that, we began to adopt different technologies, and within 3 years, 40 different physician practices, our blood pressure to goal rate was over 90%, which is pretty much unheard of. You fast forward, and then we get into the era where we now have the electronic health record. We can't do paper any longer. That's ridiculous. And this is where MedsEngine came into vogue, because we now needed software to begin to take all the data that we need and go forward. So then we added a couple more chronic diseases, and that's what we'll talk about today. So literally the challenge in managing 4 chronic diseases are significant. Guideline-directed treatment really improves control dramatically, but it's very difficult and time-consuming to do this for clinicians. The one I just mentioned, hypertension, there are 37 different variables I have to know, I have to find in my chart, and then I have to run them through a 214-page guideline. Who has time to do that in a primary care office? It just can't be done well. And that's part of our issues. If we then add all the other diseases, or 3 more diseases that we've really focused on, but are really quite significant, take a look at the number of variables that you need to know, look at the number of pages of guidelines that we need. Those guidelines are excellent. We just need to figure out how to follow them. So what we were able to do is find a way to find all 160 variables. I don't have to memorize them. I don't have to search for them. I can immediately find them, run them through 855 pages of guidelines, and then we can provide guideline-directed recommendations. And the key to this is we do it in seconds. And the reason that's important is because of those 2 pictures. There's a provider and patient, and this is where I want to spend my time, was going over the recommendation, what the guidelines are going to show, so the patient understands this is my problem, I recognize my risk, and now I get to explain to them why the guideline has personalized this recommendation to them. So that's the key to what we're going to begin to do. So once again, you're going to keep seeing this picture. This is what happens when I'm in an office if you're the patient. So what we really want to do is activate that patient so we have meaningful conversations, and when we begin to do all of this, we get much better outcomes. So what we are simply is an EHR, Integrated Clinical Decision Support application. We deliver those guideline recommendations, evidence-based, in a matter of seconds for those 4 particular chronic diseases. So in this particular case, we are not, we don't have hallucinations. We're not using AI for this. We're actually using the guidelines. So the source of truth is there. We can go back through the glass box and see exactly why these recommendations are there. The other part is, we improve key metrics. So I don't care what your driver is. When I can control your chronic disease, things are going to happen in a good way. So whether your financial driver, star ratings, HEDIS scores, value payments, were quite significant now, are great. And then bottom line is the primary care physicians are finally going to get reimbursed for some of the work they've been doing for a long period of time. It's also important to know what we're not. So this is not an expensive outreach program that's going to require a lot of different FTEs. Things like registries, identification tools, we're none of those. We're not a dashboard. They are excellent. They identify the problem, but once identified, then we're going to take a look at that and figure out how to control those particular problems. So up-to-date, open evidence, they're going to give me the guidelines. I got to go through those. We're not going to give you the guidelines. We're going to give you the end point of what the guidelines are going to recommend to you based on your personal situation. So how does this look if you go in to see your physician? When you're there, they're going to have an EHR. They're going to have different forms. This is a snapshot of part of one. and highlighted is the MedsEngine button. So that's when you and I have decided we're going to work on either one of those or all four of those if you want at the same time. When you push that button, that is step one. In step two, what we've done is we send a message up into the cloud where MedsEngine resides. It comes back to the EHR, does not go into the EHR, so it's very secure. It says, I need those 160 variables. Once it gets the variables, it goes back up into the cloud, goes through those 855 pages of guidelines in step three, and then produces that recommendation. So the fourth step, once again, is that same picture. I'm sitting with the patient, having a conversation about what's my problem, what's the severity, and why is the guideline going to begin to fix this. So what are some of the results? So if we look at this, blood pressure to goal for years has been 140/90. This is the era that I worked in. There's some controversy about is it 140/90, 130/80. We'll put that debate off later. But what we have is our data set was at that time 14,000 patients, 10 years of data. I'm a family physician. Our group was just trying to do a great job. Someone finally got a look at this and says, Doug, you need to publish this. And I said, I'm a family doc. I don't do that. They helped me. We wrote an abstract. I did not know that when you write an abstract and it gets submitted, this time it was to the European Society of Cardiology, you have to go over and present. So family physician goes over to present to cardiologists on how to treat hypertension. So we did that. When I got back, the American Heart Association calls and says, hey, what about us? And the reason they wanted to talk about this was the following. There is this blood pressure control rate in the U.S., 48%. That's today. That's not tomorrow. This is today. It wasn't yesterday. The group in Pittsburgh, 85% to goal. Pri-Med physicians, 92% to goal. The significant part about that number, that has been for 10 consecutive years. The only question I got from the cardiologist was, did you decrease heart attacks and strokes? And my response was, you taught me in medical school I would do this. Now I have to prove it. The guys who get the data came back and simply said, don't worry about that. Yes, we do decrease myocardial infarctions and cerebral vascular events. Wrote another abstract, and then we had to go to London and do that one. In the meantime, they said, I got something else for you to write. One, not only are you doing all these things, you're doing this very quickly. So when we know the cause of high blood pressure, I can really treat this quite accurately. We're doing this in less than 2 office visits. That was the third abstract, and then we end up in Milan. So this is getting really interesting for a family physician. Why is this important? If we just look at hypertension alone, chronic disease control really is cost control, and that's a big issue in this country. So this is an old study out of Lancet, a 10-point drop in systolic blood pressure. So when your physician says you're 140/90 or 150, it's that top number, you're just dropping it by 10 points. Look what happens when it gets controlled. A lot of bad things go down significantly. So major adverse cardiovascular events, stroke, heart failure, et cetera, they go down. But what also goes down is someone's not paying for those costs. And oh, by the way, my patient's not suffering from that disease either. So with all of that, our data simply, we went back, pulled it out again, didn't know we had the data. We're dropping our systolic blood pressure rates by 22 millimeters of mercury, the group in Pittsburgh by 18. The data clearly shows if you drop it even more, you get better results with doing this. Why does this come into a bigger picture? We have studies out of Ochsner, a validation study. The CDC will show it's $2,500 per year savings when you take a patient with uncontrolled hypertension and then you control it. If you then go to one of the other modules with diabetes and begin to control it, it's $2,000 per patient per year. So you really begin to make a significant impact. We did not have data on cholesterol until Johns Hopkins came out a year ago. And interestingly, they said these guidelines are great. 77 factors to control cholesterol. Who can do it? So that what they said was, if you could, what would happen? The U.S. would save $23 to $25 billion per year if we just did something that was, quote, that simple. This ends up being a quite significant number. And by the way, cardiovascular events drop significantly. That's why there's the savings. And it's about $780 per patient. So if you had a, quote, triple goal or triple aim, you can save significant number of dollars to do that. The other part is that we still live somewhat in a volume world. In general, we don't like volume because a lot of volume is the wrong thing. We're paying too much. But when you have a high-value payment for something, you want a higher volume. There's something called cardiovascular risk reduction counseling. If you had it, fantastic. It's not done very much. The issue is documentation and time to do that. So we greatly simplify this time to make it very meaningful. The major insurance companies pay a significant amount for this. Interestingly, if you take a single example, CMS finally said, we're not doing enough of this. Let's pay the docs more. They bumped it up to $31. But if I use $25 as what the reimbursement is for a single patient, take a look at what happens. Second line, by the way, this is an inexpensive tool. We are 45 cents per member per month, which is a cup of coffee a year. So this is very inexpensive. So on this code alone, that's $19 a patient that you get reimbursed for doing the right thing. If half of your patients, 2,000 is generally what we use, you have to take 1,000, it's about a $20,000 income boost for the primary care physician. That's immediate and upfront. Value is where the big dollars are, but they get paid a year later. They'd rather get paid upfront too. So that's another way of doing it. A lot of physicians, medical groups, and hospitals are driven by these quality ratings. So if we look at the star ratings and HEDIS metrics, if that's your financial driver, quite significant numbers. So these are things that we can do easily: blood pressure, statin therapy, glycemic evaluation, kidney evaluation with this. And then the other part is you use the guidelines, you get the medication recommendation. If the patient doesn't take it, it doesn't make any difference. So part of what we also do is interact with that patient. That's why that picture is so important, to get the medication adherence, because you can't get these blood pressure control rates unless the patients understand, take their medications. So if you look at these 8 metrics, 5 of these are 3X metrics. These are huge financial drivers for folks to begin to do this. So with all that being said, we also now have a new metric, 130/80. We can talk about that sometime. We can also drive to that particular number. So we got fantastic guidelines that came out last fall. We have a lot more patients now, and we have a lot more. The blood pressure control rate, by the way, for this goal is 21% in the United States. We can now drive to that particular number. So that's what we end up doing. And lastly, I can say, thanks to Stan and HITLAB, after going through unbelievable stuff, they produced this yesterday. So we finally have a summary of evidence paper that's out. The other one that happened a year ago, the group I'm working for independently, Anthem, basically, we did not know this was going to happen, came out and simply said, hey, you guys are one of the 5%, have now won the Care Provider Recognition Award. And if you look at it, the top awards are top performing medical groups, unparalleled patient care, and then chronic disease. And I know that's what they want, because that's where they save their money. So they were very happy to have that done. So if you look at this at the end of the day, physicians can now make not only quick decisions, but very accurate guideline-directed decisions and recommendations, much better care, and by the way, then they can get paid for doing some good work. What happens with patients? They're healthy and happy. That's really the bottom line as a family physician. They're fun to take care of. They become your friends, not your patients. So if you get them in control. So that's what we're really trying to do. So I'm going to show you a quick demonstration, because I keep telling you 10 seconds. I want to show you how this is done, but this is what we get to in diabetes. So you can't see this, I'm guessing, from that distance, but this is a thing that we found out that patients react to a format, how it's presented. So we adapted this in the office when I realized what got them excited. Red, yellow, and green, no matter what those numbers are, most of us can figure out you probably don't want to be in red. Yellow's probably better, and really I'd like to be in green. So I'll read this to you, but in diabetes, I want them to understand, if you're in the red area, it says likely causing damage to heart, arteries, eyes, and kidneys. That's pretty blunt. We need to get out of there. Yellow is better. It's reduced harm, but it's still harm. And then green is going to be the lowest risk. That's what we really want you to do. Oh, by the way, there's a personalized A1C down there. The ADA, American Diabetes Association, has been begging us to do this. It's 35 factors that you need to run through a calculation. It's not done because you can't do it. This happens now with software in seconds. So I don't overtreat or undertreat my patients. Either one of those can be problematic with what we do. So with that, let me try and see if I can do the technical part and do this demonstration for you. Have you be the patient. I would go exactly how we get through there. So I get 10 seconds to get to that meaningful conversation. And the beautiful part is once you realize that, then I can tell you specifically why this drug is going to take care of that problem. And when that happens, it begins to work. For the providers in the room, there's tons of other functionality in there that are there to make it extremely easy for what you begin to do. But bottom line is, eventually we're going to control these things and do some of the things I mentioned. Thank you.